Dr. Vardhaman, who is also a fantastic cataract refractive surgeon, massive practice in Pune. Over to Vardhaman.
Thank you very much, Dr. Kumar, and thank you for the kind invite to be part of your amazing course, which is always well attended with a lot of curiosity and many learning points for each and every one. So basically, no financial disclosures. I would like to also acknowledge contribution from my colleagues, Dr. Nidhi and Harshul as well. So friends, we all know that when it comes to the lens capsule, actually the lens capsule is the thickest basement membrane in our entire human body. But it is only 4 micron in thickness when it comes to the posterior pole. Prevention and the preparation for PCR is possibly the most important thing if it comes to the paramount optimal outcome for our phacoemulsification surgeries. And of course, these are kind of eyes where you should be already prepared that the patient may actually showcase a formation of PCR, such as this patient who has possibly a posterior polar cataract, patient with trauma, patient with intumescent cataracts, patient with extremely shallow AC, especially if you're not able to see the PC very well. And the studies have also seen that the PCR rate is also higher in patients who have pseudoexfoliation as well as high myopia. This is a fantastic study which has been published in ophthalmology. You can see that in the study of a large scale, 48,000 eyes, 1.8% eyes had actually encountered a PCR, and the most frequent occurrence occurred during the phacoemulsification itself, which was followed by irrigation and aspiration stages. So these are the stages where we have to be extremely careful. The risk factors for poor outcome, in spite of having PCR, you can have a very good outcome, but the poor outcomes can occur if the patient is very old, more than 65 years, if there is a dropped nuclei, if there is inadequate vitrectomy, which is the most important deciding factor for your post-operative outcomes, and of course, if you can avoid other complications. A missed PCR can cost you dearly. If you look at this surgical case, you will see that this lens is actually not rotating very easily, but there has been multiple, let's say, quadrant hydrodissection being tried, but the PC is not seen, the wave is not seen because the visualization of the PC is extremely poor. In this case, you can see that the lens is probably, you can watch, the lens is probably showing a small wobble. You can see that the surgeon is actually trying to do this into the stop and chop kind of technique, and now the groove is being deepened. But you can see there is a sudden shallowing of the pupil that you would have noticed here, and wow, now there is a complete nucleus drop. So if you are not able to recognize the PCR in time, this can actually cause devastating complications, and there can be fortunately very good signs that you can note, such as sudden pupillary bounce, constriction of pupil, which is also known as a pupillary snap sign. If you are unable to hold or chop the nucleus, which was being chopped very well, if the rotation is being very difficult because there is no counter traction from your posterior capsule, if there is a change of anterior chamber depth suddenly when you are doing a phacoemulsification or even when you are doing IA, if there is an inability to aspirate epinucleus, which you are able to do it before, but suddenly now there is a loss of efficiency of both phaco as well as IA, so this should actually preclude you and make you understand that there is something else happening, maybe something is occluding the tip apart from the cortex. Of course, there are certain obvious signs, such as if you have a picking of pupil, if there is a decentered lens which is not being centered very easily, and of course many times you can see fine lines on the posterior capsule itself. This pupillary snap sign is one of the most ominous signs if you want to actually know that there is a possibility of sudden breakout of the PC, as you can see here. And of course, if the rotation is being difficult, you actually have to understand that there is no counter traction, as we discussed. And if you are not able to aspirate the nucleus or the cortex, there can be a pre-evident PCR there. Of course, many times, as we have seen, if there are frank lines on the posterior capsule, this is a very, very, of course, obvious sign that you are dealing with an eye which has encountered a PCR. When you encounter a PCR, adequate removal of residual lens material and the vitreous is of paramount importance, and leaving behind as much as capsule so that you are able to support a lens implant. So what are the key points? Avoid a knee-jerk reaction, avoid abrupt pulling out of the phaco, make sure that you are actually maintaining the compartmentalization and also the pressure in the anterior chamber. Keep your foot pedal in the position 1, reduce your bottle height so that you are not, let's say, blowing out the PC even more, reduce the aspiration flow rate, and use the dispersive viscoelastic to create what is called as a compartmentalization. What is compartmentalization? If you see that there is a PC dehiscence here, the vitreous will try to come up, but if you use a dispersive viscoelastic and you clock or you plug the PC there, the vitreous will not come up, and then you can use even a HPMC or cohesive on the top of it so that you can do the rest of the procedure. Always make sure that you have your emergency kit with you, which should have the tricot, which should have a nice needle holder, a suture, a 3-piece lens in your library as always, and a viscoelastic which should be dispersive. So of course the next steps is to do a very thorough anterivitrectomy without damaging the other parts of the eye and securing placed intraocular lens. What you have to understand here, when you are actually using a phaco-pedal, it works very differently than when you actually want to do anterivitrectomy. In anterivitrectomy, you have to understand when you go to the position 1, of course it is going to be irrigation, but then you should go to the vitreous cutter, and that should be followed by the aspiration and not the other way around. Otherwise you will be causing a lot of traction onto the retina, giving rise to a obvious retinal detachment. Now let us understand the principles of anterivitrectomy in this case, in which we are actually encountering a posterior polar cataract. So if whenever you have a posterior polar cataract, you know that you should actually have a capsular rhexis which should be of the mid size, not too big, not too small of course. Once it is done, you can also do what is called as the mechanical mechanical dissection, that is you are separating the nucleus, the epinucleus or the cortex from the capsule with only mechanics, but here we are trying to do multi-quadrant hydrodelineation. You must not do hydrodissection as has been taught to us time to time. This is a NS 2 to 3 cataract, so basically it is important that you actually don't try to rotate the nucleus, and you have to avoid any kind of forces turning the posterior capsule, causing any kind of traction onto it. So the chopping has to be done in a vertical fashion, and it has to be done in very, very delicate fashion without causing too much of anterior chamber fluctuation. You can see that without causing any rotation of the nucleus, these pieces are being taken out one by one. It is important to fill the viscoelastic time to time without removing your phaco probe, and use a dispersive viscoelastic as we have discussed. So now we have almost removed the large chunk of this endonucleus. Once that is done, of course, you have to make sure that you remove the epinuclear plate. So that is being done very, very gently without causing, again, any traction onto the PC. And the viscoelastic has been filled time to time. But you can see now that once we are at the end, fortunately, we have removed the vast majority of the endonucleus and also the epinuclear plate. But when you are at the end, of course, in these cases such as a true posterior polar cataract, you can still encounter a posterior capsular dehiscence, which has been seen here very well. Once you see the posterior capsular dehiscence, the most important thing, as we discussed, is to avoid knee-jerk reaction. Go with your dispersive viscoelastic, and now once the chamber is formed, then only you pull out your phacoprobe. So you can once again see the time when this posterior capsule had opened up from the pre-existing PPC in this case, in this particular case. Once that is done, and once you have your good amount of viscoelastic which is plugging the vitreous on the back, and then you have to use a tricot which is going to basically stain your vitreous. It is also a good idea to make probably one more incision so that you can have a completely fresh entry in this thing. This tricot is actually, now you can visualize the vitreous very, very well. Then go ahead with your vitrector. With the vitrector, make sure that you do a very thorough vitrectomy, removing all the vitreous that has been prolapsed in the anterior chamber and also at the bud, which is at the junction of your posterior capsule and below, so that the vitreous becomes completely dissociated from the anterior chamber. Make sure that you keep filling the dispersive viscoelastic time to time. Once you're sure that your vitreous has been completely cleaned off, you go ahead and you can do a regular IA. Make sure that you do it very, very gently still, and make sure that you're not going to enlarge this posterior capsular rupture. Now this is the viscoelastic which is being basically injected again and again, as you can see. Make sure that you don't even overfill the chamber, because if you're going to overfill the chamber, it is going to cause a more blowout of the PC. You can see it's a very typical posterior polar cataract kind of opening, which is like this, which is like a spindle in shape, as you can see it here. Fortunately, once you have taken care of the vitreous very well, it is not going to enlarge. And again, make sure that you have put in your viscoelastics in place. Always, as we discussed, make sure that you have a 3-piece lens in your library. This 3-piece lens has to be loaded and has to be implanted into the sulcus. And you can see it here, you have to be very, very gentle. Just go below the iris and in front of your very good created anterior capsular rhexis. Make sure that this is being rotated in place. And once it is done, you can do also the anterior capsular capture. You can do a capture of the optics so that the lens remains very, very stable. You can use intracameral pilocarpine at the end so that basically you avoid any kind of even vitreous to come out after that as well. Once that is done, it of course gives you a very, very good outcome. So if your PCR is small, it can be converted into a PCC and you can implant the lens into the back. If the PCR is slightly on the bigger side and you have the intact ACC as we have seen in the previous case, we can still implant the lens and do a capture. But if you have a larger PCR with the questionable support of the capsule, you also have the option of doing suturing of these 3-piece lenses to the iris. My mentor, Professor Sonia Yu, was a large proponent of that, and I have seen her doing this time and again, and I have done a few myself. And of course, if there is no capsular support at all, then you have options of doing the iris claw lenses, scleral fixation, or the, of course, you should avoid ACIOL in the current times. So to conclude, the PC rupture or the posterior capsular rent is an important complication of phacoemulsification. A careful and diligent handling of PC, early detection of PCR, and meticulous vitrectomy with preservation of capsular support as much as possible is of paramount importance. Understand the principles of anti-vitrectomy, that is the cornerstone of the success of PCR management and your optimal outcomes post-operatively. And the location of the IOL implantation and the design, it will be very carefully chosen depending on how much capsule you have left, and that is going to optimize your long-term outcomes. So thank you very much for your kind attention. Thank you. Thank you so much again, Dr. Kumar. Thank you.